as we have already finished the muscles of the gluteal and thigh region, next we have the muscles of the leg. It means the muscles which act on the leg, ankle joint, and the small muscles of the foot. So here this you have few slides just to revise your bones. So if you see the leg region, it is also divided in the three compartments like the thigh. But if you remember, in thigh we have anterior, posterior, and medial compartment, right? But in leg region we have anterior, posterior, and lateral compartment. Okay, the lateral means we have the fibula bone. Okay, so here we have the muscles. They are called as peroneal muscles. So in lateral compartment we have peroneal muscles. They are responsible for eversion of food. Okay, now we all of us know that what is inversion, what is eversion. Okay, so here we have the peroneal muscles responsible for eversion. So what is the nerve of the lateral compartment? That is superficial peroneal nerve, and the artery, the branches from peroneal artery. Then we have the anterior compartment. So in anterior compartment, the muscles, they are called as extensor muscles. Which nerve will be there? So we have the deep peroneal nerve along with anterior tibial artery. What about the posterior compartment? So the posterior compartment, it is called as flexor group or flexor muscles. Okay, posteriorly we have the tibial nerve and posterior tibial artery. Okay, do you remember tibial nerve? It is coming from where? It is a branch of what?
sciatic nerve.
Very good. And what about the peroneal nerves? So we have superficial and deep, which is which will be coming from the common peroneal nerve. So now we have two branches from the common peroneal nerve and tibials. These three nerves are important in the leg and foot. First, we will see the lateral muscles. So if you remember in the first lecture itself, I told you peroneus means related with fibula. So we have peroneus longus and brevis. So longus, here you can see it is a long muscle. It will take origin from the upper part of lateral surface of fibula. Same way brevis means short or small. So it will take origin from the lateral half of the lower part of fibula. Okay, what is the nerve supply? Same, superficial peroneal nerve. Both have same nerve supply. It is the branch of peroneal artery will provide the blood supply. So here we can see the origin. Now what about the insertion? As it is a long muscle, so you can see that from here, okay, from the lateral malleolus, this muscle is crossing the plantar surface. Okay, the plantar surface of all the metatarsals and tarsals, and finally it is getting inserted over first metatarsal bone. Okay, so you can say why it is longest, because it is coming from upper part of the fibula and it is crossing all over the plantar surfaces of all metatarsals. Okay, what will be the action? So obviously these muscles, they will do eversion. Along with the eversion, they are responsible for the plantar flexion. We have the peroneus brevis. So again, it is a short muscle coming from the lower part of the lateral surface of the fibula. Okay, when you cut the longus, you can see this is a brevis in the lower part. Okay, and it will not go much towards the other part, just it will be inserted over the lateral surface of the fifth metatarsal bone here. Okay, the action, it is same as the peroneus longus. It is also going to do plantar flexion and eversion of food. So what about the superficial peroneal nerve? So it will arise from the common peroneal nerve. Where did this division occur? If you remember in our model, we saw that the common peroneal passing through the head of the fibula. Okay, so at the lateral surface of the neck, this nerve is going to divide into superficial and deep branch. Okay, superficial is going to supply to the lateral compartment, and also it will give the cutaneous branches for the lateral side of the leg and also for the dorsum of the foot. Okay, and all the dorsum of the foot and toes except the first interdigital cleft. Okay, so these all will be supplied by the superficial peroneal now. It means two muscular branch and a cutaneous branch. What about anterior compartment? So in the anterior compartment, we have four muscles. Okay, so just you have to remember the sequence. Whenever you study muscle, remember with the sequence, tartib, which is medial, which is next, which is next, which is lateral. Okay, so the first muscle you will start from medial side, it is the tibialis anterior. Okay, then you have the next muscle which is going to the great toe. Okay, in upper limb. You remember for the thumb, we have muscles called as pollicis from P. Pollicis like flexor pollicis longus, extensor pollicis longus. Okay, but here for great toe we have hallucis from H. Okay, so we have the extensor hallucis longus. Then we have the extensor digitorum longus. So digitorum means going to divide into four digits. Okay, except the great toe. Same like upper limb. In upper limb also we have the digitorum which divides into four slips and inserted over the four digits. Same here also. You can see 1, 2, 3, 4. Okay. Then we have fourth muscle that is called as peroneus tertius. Okay. So what is tertius? It is third peroneus muscle. Tertius means tertiary, primary, secondary, tertiary. So this is the third peroneus muscle, okay, which is not in the lateral compartment. It is in the anterior compartment. Okay. What is the nerve supply? Deep peroneal nerve and artery by the anterior tibial artery. So what will be the origin? Obviously, the tibialis anterior will take origin from the tibial bone, okay, and also from the interosseous membrane. Its insertion, yes, it is the first muscle medially, so it will be inserted over the base of first metatarsal bone. Okay, so just remember all these muscle, whatever now you will study, they will be responsible for extension. It means now we don't call extension. What do you call? Dorsiflexion. Okay, dorsiflexion. So all these muscles will be responsible for the dorsiflexion, okay, at the ankle joint. Then this tibialis anterior will also do a action known as inversion of the foot at subtalar joint. They are important to support the medial longitudinal arch of foot. Okay. Then next we have another muscle which is going to the great toe, distal phalanx of big toe. Okay, this is the distal phalanx. You remember this is distal, this is proximal. But in other toes, we have distal, intermediate, and proximal. So this also will take origin from the fibula and interosseous membrane, and its insertion is over the distal phalanx of big toe. Okay, now you can imagine it is crossing the ankle joint, okay, as well as it is crossing the joints of the big toe. So it is going to do dorsiflexion at all these joints. Okay, dorsiflexion at ankle joint as well as dorsiflexion of the big toe. Then next we have the extensor digitorum. Okay, so again it will come from the anterior surface of the fibula. Then finally it divides into four tendons. Okay, and they are inserted over the middle and distal phalanx of all the lateral four toes. Okay, so I will not make you confuse. If you remember, in the upper limb there were two muscles, one superficial, one profundus, but here no, here only one extensor digitorum here, okay, which is coming from above. It will be inserted over both middle and distal phalanx. Okay, so same way it will do dorsiflexion at ankle, as well as it will do dorsiflexion of all the four joints of the lateral four toes. Then we have the peroneus tertius. Tertius means, as I told you, the third peroneus. Okay, here you can see this is also a small muscle taking origin from the fibula. And what is the insertion? Over the fifth metatarsal bone. Okay, its action, because it is from the dorsiflexion group, so it is going to do the dorsiflexion and as well as eversion of foot at the subtalar joint. So the last time we saw the arteries of the lower limb. In this we saw we have the main femoral artery, which becomes popliteal artery in popliteal region. Okay, then it divides into anterior and posterior tibial artery. Okay, so this is the anterior tibial artery, which is present in front of the interosseous membrane. Okay, and here, if you remember here, it will become the dorsalis pedis artery. Okay, between the two malleoli. Can you see? Okay, it is present between the tendon of the hallucis and digitorum. Okay, this even you can feel in yourself also, you can feel this pulsation. In lower limb, if you have to feel pulsation, you can feel from here, from the dorsalis pedis artery. Okay, so next we have the deep peroneal nerve, which is coming from where? Just now we saw that it is another branch from the common peroneal nerve at the neck of the fibula here. Okay, it is accompanied by the anterior tibial artery. It will give muscular branches to all the muscles of anterior compartment and also extensor digitorum brevis. Okay, you will see what is extensor digitorum brevis. Now you will see that there is a small muscle and it will give cutaneous branch to first interdigital cleft at this area. What will happen? Can you imagine what will happen if there is injury to the common peroneal nerve? Okay, if there is injury to the common peroneal nerve, the patient will not be able to do this action. Okay, the patient will not be able to do. So here you can see that when extensor digitorum longus will contract, it will take all the tarsals, metatarsals up. Right? It means the dorsiflexion. But you can imagine if this muscle is not acting, so the tarsals means the foot will drop. Okay, so what do you call to this condition? Foot drop. Okay, when the foot drop will occur, the foot drop will occur if there is injury to the common peroneal nerve. And where it is common here. Okay, if there is any fracture to the upper part of fibula, maybe head, maybe neck. So if they ask you which nerve injury may cause the foot drop, you should know it is common peroneal nerve. Clear about the anterior compartment? Okay, let's move to the posterior compartment. So the posterior compartment, okay, it has little more muscles than the anterior compartment. First of all, we have the superficial group and deep group. In superficial group, nicely in all our specimen, we have the gastrocnemius muscle. Okay, We have the soleus muscle and the plantaris, which is in between. In the deep group, we have the popliteus, flexor hallucis longus. Okay, hallucis means going to the great toe. Flexor digitorum longus. It means dividing into four slips going to lateral four digits. Then tibialis posterior. Okay, so as we have the tibialis anterior, same way we have tibialis posterior, which is present in the posterior compartment of leg. So this gastrocnemius, it is also called as calf muscle. Okay, it has two heads, lateral and medial. So lateral will come from the lateral condyle of the femur bone. Same way the medial will come from the medial side of the or medial femoral condyle. Okay, then what is the insertion? Okay, if you see this tendon, it is even you can feel on yourself, this is very thin, thick. This is the strongest tendon in our body. Okay, so it will be inserted to the posterior side or posterior part of the calcaneus through the tendocalcaneus. Okay, this tendon it is called as tendocalcaneus, tendocalcaneum, or Achilles tendon. What will be the now? Yes, because it is in the posterior compartment, so we have the tibial now. Okay, what it is going to do? Flexion of the knee. Yes, because it is coming from the upper aspect. So yes, it will go do little bit flexion at knee and as well as the plantar flexion of the knee of the ankle joint. Now this is a plantaris muscle. We cannot see in our model because this is very thin, which is present between the soleus and gastrocnemius. Okay, and most of the time it may be absent. So if it is present, it will take origin from the lateral supracondylar line. Okay, then insertion is again via the tendocalcaneus. Nerve supply, tibial nerve. Same, it will also do a flexion of knee and also a plantar flexion of the ankle joint. Then we have another big, a bulky muscle. Okay, you can feel this posteriorly. The gastrocnemius and soleus is forming a big bulk. What is the origin? Do you remember the soleal line on the posterior aspect here? So it will take origin from the soleal line of the tibia and also this is from the head of the fibula. Okay, it is also inserted over the posterior aspect of the calcaneum through the tendocalcaneus. Okay, the nerve supply, yes, the tibial nerve. What will be the action? So as we know, this is responsible for the plantar flexion of the ankle joint. Okay, and this is the muscle which has many small venous plexus inside. Okay, because when we are standing for the long time, okay, so the venous blood may accumulate here. Okay, the venous blood may accumulate here. So when this muscle will contract, all the venous blood will go above, go to the veins and finally to the inferior vena cava and to the heart. Okay, so it is called as the peripheral heart. Okay, that's why it is called as peripheral heart. Okay, you understood? Even sometimes the person when is too tired, just they will do massage over the calf region and they feel better. Why? Because it has the venous plexus in which sometimes the venous blood will be accumulated. So when you do some massage or little bit exercise of this muscle, you will feel better. So we have the tendo-achilles. It is also known as tendocalcaneus. It provides attachment to the gastrocnemius, soleus, and plantaris to the calcaneum. Okay, this is the calcaneum, which is called as heel bone. Okay, then this is the thickest and strongest tendon in our body. So what are the muscles now in the deep groove? So this is a very small muscle here. Okay, this is a very small muscle here. This is called as the popliteus. Okay, now if you see the popliteus, this is called as popliteal fossa, right? This is called as popliteal fossa. So this muscle is forming the floor of the popliteal fossa. It will take origin from the lateral side of the femoral condyle, and it is inserted over the posterior part of the upper side of the tibia. What is the action? Okay, so just if you see in the books, they have mentioned many actions. We will just remember that is it is a flexor. Okay, and it will help in unlocking of the knee joint from the standing position. Okay, so flexion and unlocking. Okay, so don't worry, now I will tell you about the joints and also about the unlocking. So this popliteal fossa, it is very easy. What will be the boundary? So in lower side, we know inferiorly, we have the medial and lateral heads of the gastrocnemius muscle. What about superiorly? Okay, so superiorly also we know we have the hamstring muscles, right? Hamstrings. So medially what is there? Yes, medially what is there? Remember? Semimembranosus and tendinosus. Laterally, what is there? Biceps femoris. So here you can see biceps femoris and semimembranosus and semitendinosus. Okay, and on the lower part, or you can see the inferolateral and inferomedial, we have the heads of the gastrocnemius. What are these structures present here? Okay, so we have the popliteal artery, popliteal vein, then the small saphenous vein, because we know that small saphenous vein will come here and it will drain out into the popliteal vein. Then we have the common peroneal nerve and tibial nerve, because this is the part where the division of sciatic nerve will occur, just above this, but in the fossa you will get both the branches. Okay, and we have some popliteal lymph nodes. So we have here the tibialis posterior muscle. Okay, so this also will come from the posterior surface of the tibia, and you can see that this will give branches, or you can see it will give small slips to all the tarsal bones, okay, except talus, and base of middle third metatarsals. Just 2 minutes. Okay, can you see my screen?
Yes, doctor.
Okay, so we were talking about the posterior compartment, okay, in which we saw the muscle as the first muscle. It was the oblivious in deep groove. The second muscle is tibialis posterior. Then we have the third muscle that is called as the flexor digitorum. Okay, so it will come from the posterior surface of the tibia and it will divide into four slips and inserted over the lateral four toes. Okay, so as it is going to cross, it is crossing your four toes and as well as the ankle joint. So it will be plantar flexion as well as it is going to flex the small joints of the toes. We have flexor hallucis longus now. So this is also a muscle of posterior compartment coming from the fibula. Its insertion, yes, it is hallucis, so it is going to insert over the distal phalanx, means the last phalanx of the big toe. So it is going to do plantar flexion at all the small joint as well as ankle joint. Okay, so now we have the tibial now. So same, it will descend down from the popliteal fossa. Okay. So now we have seen it is going to give the muscular branches to the muscles of the posterior compartment of the leg and also to the knee and ankle joint. And it's one of the cutaneous branch which is also known as sural now. Okay, sural now, which is giving the cutaneous supply to the posterior or posterolateral side of the leg, okay, and foot, and also the lateral side of the little toe. Then we have the medial cutaneous or calcaneal nerve, which is a cutaneous supply to this area, okay, to the heel. And finally, this nerve will divide into medial and lateral plantar nerves. So you can imagine its injury is less common, but suppose there is any problem with the tibia, any fracture in the tibia, it may cause the tibial nerve. Okay, so there will be loss of the plantar flexion. Okay, so you can imagine if you cannot do plantar flexion, so just you have to walk with the dragging your foot. Okay, you cannot do, just you can try that you are not able to do your plantar flexion. So simply you will walk with the getting heel on the ground. Okay, so this is a shuffling gait. Okay, this is different from the neurological. This is the shuffling gait due to the local neurological injury. So the deep muscles, you will be happy that no, we don't have the specimen to see the deep muscles. No, but you can identify these deep muscles at the ankle joint. Okay, ankle joint, at the ankle joint, you can see the tendons. Like first, we will see the anterior and extensor compartment. So we have the band of the deep fascia, like upper limb. Here also we have the retinaculum. You can see this deep fascia, it is bounding or binding the tendons together. So you can identify from the medial to lateral side. The first tendon will be tibialis anterior. Second tendon will be extensor hallucis longus. See where it is going to the great toe. Then we have the vessel and nerves, anterior tibial vessel, the peroneal nerve. Then we have the digitorum muscle, and then we have peroneus tertius. Okay, so this structure you will try to identify. Okay, so you have the mnemonic. Tom has very nice dogs and pigs. You can try to memorize with this. Next, posteriorly, we have the, again, only you can identify the tendons of the deep muscles. Okay, so these muscles, they are under cover of the flexor retinaculum. So from medial to lateral side again, you can identify first muscle as the tibialis posterior, then flexor digitorum longus, then you have the tibial nerve and posterior tibial vessels, then the flexor hallucis longus. Okay, even you can try to identify this in our specimen. Okay, so this is all about the muscles of the thigh region. Now we have the muscles of the foot. So if you do dissection of the foot, even if you try to pinch your skin of the foot, you will see that below the skin directly you cannot feel muscles. You will feel it is thick. Why? Because we have this deep plantar aponeurosis, which is a deep fascia. Okay, so it will be attached to the toes anteriorly all the five, and posteriorly it will be attached to the calcaneum. Okay, okay, it is responsible for maintaining the longitudinal arches of the foot, and also it will protect the underlying structures like nerves and vessels. So when you remove the deep fascia, okay, or plantar aponeurosis, you will see muscles are arranged in four layers. Okay, the muscles are arranged in four layers. So just I will give you a small hint. In the first and second layer, you have three small muscles. Okay, in first and third layer. So this is the first layer. Here you have two abductors with one flexor in between. Okay, like abductor hallucis, abductor digitiminimi. Okay, and in between you have the flexor digitorum brevis. What about the third layer? Yeah, third layer is opposite. You have two flexors with one adductor. Okay, just see carefully. It is not abductor, it is adductor in between. Okay, so flexor hallucis brevis, flexor digiti minimi brevis. Okay, in between you have adductor hallucis. This is about first and third layer. Okay, what about the second and fourth layer? So in second and fourth layer, you have two long tendons and two small muscles. Okay. So in second layer, you can see you have flexor digitorum longus. This is flexor digitorum longus with the lumbricals. Okay. And also this is the flexor hallucis longus. It is present in the second layer. Okay, then this is the muscle. You can call it quadratus planti or flexor digitorum accessorius. Okay, so this and lumbricals, two small muscle, and this digitorum and hallucis, this two long tendons. What about the fourth layer? So in the fourth layer, again, you have two small muscles, two long tendons. Which two long tendons? Tibialis posterior, okay, peroneus longus. What two small muscles? Interossei. Do you remember interossei from the upper limb? The interossei means interosseous, means between the two bones. Like here between the metatarsals, we have the muscles. Okay, anteriorly and posteriorly. So they are called as plantar interossei and dorsal interossei. So we have the three plantar interossei where they are responsible for adduction. Okay, adduction. Dorsal interossei, they are four in number and they are responsible for abduction. Okay, so here all the muscles if the sole, whatever you have studied, they are supplied by lateral plantar now, except four muscles. Which four? You will see mostly they are related with the great toe, like abductor hallucis, okay, flexor hallucis brevis, first lumbrical, and flexor digitorum brevis. These are the four muscles which will be supplied by medial plantar now. Okay. So just I will not make you panic because we have practical. So it is easy. How many groups we have in the leg region? Three. Anterior, posterior, lateral. Okay. Laterally, you will see two muscles, peroneus longus brevis. Anteriorly, you will see three muscles. Okay. Tibialis anterior, four muscles. Tibialis anterior, then, yes, hallucis, extensor hallucis, extensor digitorum, and peroneus tertius. Same way, posteriorly, you will have tibialis posterior, then you will have flexor hallucis longus and flexor digitorum longus and popliteus. Okay, from the deep group, superficially, we have the gastrocnemius, soleus, and plantaris. Okay, so now we know all the muscles, right? So just I will take only 5, just 10 minutes, and I want to show you a small revision for your. Okay. So inshallah, again in your mashra, in your lab, you can see the joints, what are the ligaments. Can you see the slides of hip joint?
No, we can't.
No? Okay. Is it visible now?
Yes.
Yes. Okay. So the joint, why I want to revise it here now, because you know all the muscles. So just I will show you what are the muscles, okay? Responsible for movement. Other things you can see in the mashra. Okay. What is the type of hip joint? We have synovial ball and socket of type joint, which is formed by head of the femur and acetabulum of hip bone. Okay. Then what are the ligaments? So as we have the three parts of the hip bone, ilium, ischium, and pubis. So same way we have three ligaments, iliofemoral, pubofemoral, ischiofemoral. Okay. Then we have the transverse acetabular ligament and ligament of head of femur. Okay, so here we can see nicely that this is the ischiofemoral ligament which is coming from the ischium. Okay, then this is the iliofemoral ligament which will come from the anterior inferior iliac spine. Okay, and anteriorly it will be till the intertrochanteric crest. Then we have the pubofemoral from pubis to femur. Then if you see from the head, in the head of the femur, we know there is a fovea, there is a small gap, or you can see there is a small depression which will provide attachment to the ligament, which is called as ligament of head of femur. Okay. And then when you see the acetabular cavity, it is bridged by another ligament, transverse ligament here, which will be called as the transverse acetabular ligament. So like this, we have the 5 ligaments. Okay, so this about the movement. Now you should be able to tell which muscles are responsible for flexion. Okay, iliopsoas, I have told you. The major or chief muscle is iliopsoas, then rectus femoris and sartorius will also help. For extension, what is the chief muscle? Yes, gluteus maximus, okay, and hamstring. What about abduction? So we have the medius and minimus. For adduction, we have the adductors and gracialis. For medial rotation, we have gluteus medius, minimus, tensor fascia lata, and then we have these six lateral rotators, small muscles. This, can you tell me the name of the lateral rotators? Any one or two? Yes, quadratus femoris, gemellus. Yes, yes, please.
Coordinate muscles, piriformis muscle,
Yes, very good. Gemellus muscles, superior and inferior,
rear
obturator,
gemellus,
intern. Yeah, very good. Okay. So here, since we know now head, we know the ligament. Okay. So this ligament of head of the femur, its function is that it carries the artery inside the head. Okay, which is a branch from the obturator artery. Can you see here? This ligament, it will take a branch of obturator artery, okay, which will supply this area. Okay. The neck has a very rich blood supply from the medial circumflex artery. Okay. So the fact is that this branch which is supplying the head, it is very small branch, and this may be absent also. Okay. So you can imagine if there is a fracture to the neck, this area, what will happen? This part, the head will not have sufficient blood supply. Okay. So in that condition, it will lead to the ischemic necrosis of the head of the femur. Okay. Why I'm telling you? Because this is more common in old age. Okay. In old age, if they have the fracture of the femur, because already they have osteoporosis, so it will lead to the avascular necrosis of head. It has two reasons. Why? First of all, the branch of the obturator artery which is coming here, it is very small. And second, it may be absent. Okay, this we have already seen. Yes, in the last lecture, we saw that the Trendelenburg sign, it depends on the gluteus medius and minimus muscles, okay, head of the femur and neck of the femur. Okay, the action of the gluteus medius and minimus is the stabilization of the hip, okay, during walking. So if there is problem with the nerve or with the gluteus medius or minimus muscle, there will be sinking or dropping down of the hip during walking. Okay, so knee joint. What is the type of this joint? This is also a synovial joint of hinge type. For knee joint, we have the four ligament. Means you can imagine it has lock from all the four sides: anterior, posterior, medial, lateral. Okay, so what is there anteriorly? Yes, anteriorly we have the ligamentum patelli, okay, which will be attached to the patella as well as tibial tuberosity. Then we have the lateral collateral ligament laterally from the lateral condyle of femur to head of fibula. Then medially we have medial collateral ligament, which is from medial condyle of femur to the medial surface of tibia. Then posteriorly we have the oblique popliteal ligament, which is the expansion of semimembranosus muscle. Okay, so in knee joint, because this is the important joint for running, for walking, for jumping. So we have specific ligaments which are present inside the joint cavity. Okay, so they are called as intra-articular ligament. Okay, the others, they are extra-articular. Okay, but this is the only joint, knee joint, where we have some ligaments to support the joint and they are present inside. So you call them intra-articular ligament. What are they? Cruciate, crossing each other, anterior and posterior cruciate ligament, and menisci, medial and lateral menisci. So if they ask you what are the intra-articular ligaments of the knee joint, so you should know the anterior and posterior cruciate ligament and medial and lateral meniscus. Okay, so this is the superior surface of the tibia where you have the menisci. Okay, now bursa. Okay, so this is something many students ask about, what is bursa meaning, what is bursa. So bursa means hidden, something which is hidden inside. Okay, so this is a specific fluid filled sac, okay, which is there around the patella to provide smooth movement. Okay, it will avoid the friction of the patella, because you know the patella, it is a bone on the lower part of the femur. So you can imagine whenever you will walk, there will be friction between these two bones? No, because we have this synovial cavity. There is a bursa which will provide a safeguard for movement. Okay. So we have which bursa? Anteriorly we have suprapatellar because it is above the patella. Then we have the prepatellar in front of the patella. Then we have the infrapatellar, which is below the patella. Okay, which is superficial and deep. Now if you see posteriorly, yes, posteriorly also we have in semimembranosus muscle and popliteal muscle. Okay, if you see books, they have many complicated story, but we just should know what is bursa. It is the fluid filled synovial membrane or sac which is present around the patella to avoid free movement. Okay, so you can see here the cruciate ligament. Then you can see here the patellar ligament. Okay, then you have the quadriceps tendon in which the patellar ligament will develop. So again, for the knee joint, we have, as it is a hinge joint, it should have flexion and extension, right? Flexion by the hamstring and extension by the quadriceps femoris. Okay, but because it is a modified joint, it has patella also, the third bone is also involved, so it can do a small amount of medial and lateral rotation. Okay, the lateral rotation is by biceps, medial rotation by the semitendinosus, brachialis and sartorius. Now again we have this thing, locking and unlocking. Just now we saw that there is a popliteus muscle which is responsible for unlocking of the knee joint. Okay, so now when you go to the lab, you try to take the tibia and femur. If you keep together one bone on each other, you will feel that both the condyles of the tibia are not of same size. Okay, so when you make full extension, like when you are standing, you cannot keep femur over the superior surface of tibia completely. Why? Because the lower part of the femur, it is not even. Both the condyles are not of same size. Okay, so now you want to stand in full extended position. Now your tibia, your condyles are not of similar size. So what you have to do? So you have to do medial rotation for the 30 degrees. Okay. So it means when you do medial rotation for 30 degrees, your knee will be locked. Okay, I know it is difficult to say like this, but when you will see the bone and just try to understand, I will show you inshallah. So you have done medial rotation. Now the tibia is over the femur and femur is over the tibia completely. You are locked. Now if you want to unlock, so obviously you have to do lateral rotation in opposite direction. Okay, so which muscle will do this opposite movement? It is popliteus. Okay, it is popliteus. Okay, so don't worry, inshallah, we will see again this in the lab. So knee joint, why knee joint is very important? As we know, this intra-articular ligament injuries are more common in the sport person. Okay, so in this, the anterior cruciate ligament, medial meniscus, and tibial collateral ligament. These three structures are very, very common to get injured. Okay, so this is the menisci. Here you can see if menisci will broken, it will appear like this. Okay, and its healing is difficult because it is a cartilage. Next, we have the ankle joint. So ankle joint, how it is formed? It is formed by the tibia, fibula, and the talus. Okay, always remember that fibula is not present in the knee joint. Yes, but in ankle, yes, it is present. In the ankle joint, yes, it is present. What is the type of joint? Yes, again, it is a hinge joint. Okay, it has lateral and medial ligament. If you see, if you compare with the hip or knee joint, you will find it is less stable joint. So the sprain, okay, and small injuries even while running also, it is possible. So laterally, we have the lateral ligament, okay, which is from the lateral malleolus to the talus and calcaneum. Okay, you can see anterior talofibular, posterior talofibular, and calcaneum. Then what about medial? Yes, medially we have important ligament that is called as deltoid ligament. Okay, deltoid ligament. So it is medially from the medial malleolus to the calcaneum to the talus to the navicular bone. Okay. So again, if you talk about the movement at the ankle, so only two type of movements you can do: dorsiflexion and plantar flexion. Dorsiflexion by the muscles of the anterior compartment like tibialis anterior, okay, extensor hallucis longus, extensor digitorum longus, and peroneus tertius. I hope you remember just now we discussed all these muscles. Then we have the plantar flexion, muscles of the posterior compartment like gastrocnemius, soleus, plantaris, peroneus longus, and brevis. They are from the lateral compartment, but they are also responsible for plantar flexion. Tibialis posterior, flexor digitorum longus, and flexor hallucis longus. Okay. Then superior tibiofibular joint, it is a plain synovial joint. The inferior, no, it is not the synovial joint. It is a fibrous joint called as syndesmosis. So now joints of the foot, so no need to worry. Okay, this is very easy to know because its name very easy. If you join to any two bone, it will become a joint. First of all, we have subtalar joint. Okay, so here if I run, but I don't think I can run the slideshow. But the subtalar, this is the subtalar joint, the first, which is between the talus and calcaneum. Okay, subtalar joint. Then the next two joints, this one, talocalcaneonavicular and calcaneocuboid, this one, this area. Okay, this area. They are called as the transverse talar joint. So these three joints, first, second, and third, please you can note down these three joints. They are responsible for the inversion and eversion movement. Okay, not the ankle joint. If they will ask you what movements you can do at the ankle, only dorsiflexion and plantar flexion. Okay. What about inversion and eversion? No. You can do on the smaller joints like subtalar, okay, and transverse tarsal means talocalcaneonavicular, talocalcaneonavicular. These three. Okay. Then calcaneocuboid. So can you see this block? Can you see this block? This is for the transverse tarsal joint. Okay, so these two and plus subtalar. They are responsible for the inversion and eversion movement. Okay, then other joint you can make like cuneo-navicular, okay, intercuneiform, okay, tarso-metatarsal, intermetatarsal, okay, metatarsophalangeal, interphalangeal, okay. So not very important. This already you have studied in upper limb. They are the plain synovial joint. Just they will avoid. They will just do gliding movement, except the phalangeal joint, which they are hinge joint. So about inversion and eversion, joints clear? Okay. Inversion and eversion will take place at subtalar and transverse tarsal joints. Okay. But what about the muscles? What muscles can cause inversion? What muscles can cause eversion? So just always remember eversion, E, will be done by the peroneus muscle. All three peroneus. Peroneus brevis, longus, and tertius. Okay. What about inversion? Inversion will be done by both the tibialis. Tibialis anterior, tibialis posterior. Okay, and also extensor hallucis longus. Okay, and extensor digitorum longus. Okay, so if you have to remember two muscles for medial for the inversion, you can remember tibialis anterior and posterior. Okay, and in extensor, two hallucis and digitorum. When you have to remember about eversion, all three peroneus, longus, brevis, and tertius. Okay. So, inshallah, it's not very difficult, but you need to see all this in the mashra. Okay, then only you will understand everything. Okay, any questions? Any questions?